Good morning, everyone. How is everyone doing? Looks like we're still waiting for a few people. Okay. 1, 2, 3, 4, 5, 6, 7, 8. All right, we'll give folks a minute here to get logged on. Alrighty, that looks like everybody. Everyone can hear me. All right, cool. So we have a couple of things to do today. We're going to review the case studies that were due today. And then we are going to be talking about adjustment disorders, which we already covered. I believe it was week 3 when we talked about anxiety and trauma disorders. But we're going to review it a little bit today since it is relevant to some of the pieces for some of the other diagnoses we're going to talk about today. And then we'll be talking about the other conditions in the last part of the DSM, which again, aren't necessarily disorders, but are things that you might be treating people for and how to code those. And then actually before that, we're going to talk about some medication-induced diagnoses. So case studies. Let me get this opened up here for you. Share screen. Mr. Schneider. What did folks decide on for Mr. Schneider? Anybody?
I did probable major neurocognitive disorder due to Alzheimer's disease.
Okay.
And I have questions about coding. For some reason, I felt like that was really difficult to understand when reading in the DSM. So I did like 331.0 Alzheimer's disease, comma, 294.11 major neurocognitive disorder due to Alzheimer's. But I don't, like, do you need to do both?
Yeah, so you always need to put, if it's due to some sort of medical condition, you always put the medical condition first, absolutely. And then the probable versus possible piece really depends on the setting that you're seeing the person. Here, we know because he had a diagnosis, right? Or am I thinking of one of the others? If they have the diagnosis, you would put probable. And the reason it's probable, not definitely, is because there's always a very, very, very small chance that the neurocognitive could be due to something else. Whoopsies, that's not what I wanted to do. I want to go here and I want to search. It's not letting me. But yes, I don't see it in here. Did he have an official diagnosis of Alzheimer's disease?
See, I don't think it was official, but he demonstrated like so many of the symptoms that it seemed to me obvious. I don't know though.
Yeah. So I would either the possible or probable would have been acceptable here. And he does show all the symptoms, and you would need to have an official diagnosis in addition to that from the other members of the care team. Somebody else put a frontotemporal neurocognitive disorder. Tell me about that piece.
That was me. I had Alzheimer's as a rule out, and I ruled out delirium too. And I think I'm like looking back now, like why I chose that. But there was, I think initially I was like, oh, that's Alzheimer's. But then when I was looking more closely at the criteria, it felt, because this is in the book, so they, in like the fourth paragraph here, it talks about he had started taking the haloperidol and then that like wasn't working. And I think that was part of it. And so that was a part of why I decided to change my diagnosis, because of the medication that what he was not responding to, in addition to the other things.
Yeah, so the haloperidol is an antipsychotic, and in of itself, it is not indicative of the actual diagnosis. It would roll out something like schizophrenia, right? As far as the vascular neurocognitive goes, we don't have enough information for that because we don't have a stroke or some other kind of vascular event here.
Even I have a question about that. So even with the EEGs and the CT scans showing like the enlargements of the ventricles and
so
like so that wouldn't even be probable, because
that would be more consistent with Alzheimer's.
Okay.
Yeah, if it was vascular, that would have to be something purely happening with some kind of blood flow cut off to some, like usually a specific spot in the brain, but this sort of overall atrophy, especially in the ventricles, would be more consistent with Alzheimer's. But again, we don't know for sure because he doesn't have the diagnosis. Some folks had also put in a delirium based on some of the alcohol use, which again would be a good rollout. However, we do want to see some of these things have been going on for long enough, and it doesn't appear to be happening only during either withdrawal or due to alcohol use. So it was really up to folks to decide if the alcohol use was so much that it could have caused some kind of neurocognitive disorder. Unlikely. 2 to 3 beers is probably not healthy. And it's not necessarily enough to cause something like a Korsakoff's or a Wernicke's dementia. So I think the most accurate, looks like Dylan posted one here, was a major neurocognitive disorder unspecified with behavioral disturbances. And then, we would want to ask more questions there based on just what we know. It's probable to be Alzheimer's, but we don't know for sure. So any of those would have been acceptable. Let's see. Sorry, my dog is rolling around and making all sorts of, in case anyone was wondering what that sound was.
So Liz, really quick on that one. So then you think that would have the best diagnosis was probably the probable Alzheimer's with behavioral disturbance.
Yeah, so either the unspecified or the probable possible Alzheimer's. I think if you wanted to be kind of safe and more conservative, I would put unspecified. But if you feel really strongly based on the things like the enlargement in the ventricles, the memory issues, how long the memory issues have gone on, all of those things, then absolutely you could go with the Alzheimer's. It really is just kind of up to your judgment there.
When you go with the Alzheimer's, does that mean you're saying there's a major neurocognitive disorder due to Alzheimer's? Is that separate? Okay.
Yeah. So anytime, and you had done that correctly, Megan. If you believe that it's Alzheimer's, you would list Alzheimer's, and then you would list the major neurocognitive due to Alzheimer's. So anytime you're listing due to a specific medical etiology, you list the medical diagnosis first. Excuse me, fighting something off. I feel like, is anyone else getting like daycare levels of ill ever since we started going maskless? Okay, that's not just me. All right. Beatrice.
I put, let me get back to it. I put major neurocognitive disorder due to another medical condition. And that was because of the subdural hematoma. And I originally had delirium, but then when I went to rule, I saw that it specifically said if you have subdural hematoma, this would fit under major neurocognitive disorder. And then I also ruled out major neurocognitive disorder due to traumatic brain injury, major neurocognitive disorder, because she hadn't been seen by the doctor right after she fell.
Yeah, so all of those make sense. Did anyone have anything different?
I did the I was a little bit confused, like Megan was, on like how to do the order. So what I wrote down was the diffuse traumatic brain injury with loss of consciousness for an unspecified duration,
Okay.
followed by the major neurocognitive disorder due to traumatic brain injury with behavior disturbances. But one of my questions for you slash just in general was the timeline of that, because it had been so long. I wasn't sure if it would meet it, just because it just says greater than 24 hours. But then in the like description part of the DSM, it was talking about like, oh, like some of these symptoms can last for a month or longer.
Yeah.
So I just wasn't sure about timing wise if that would meet the diagnosis.
Well, the way that you wrote it out is correct, right? So you put the injury first, followed by the neurocognitive disorder due to the injury. The timing here, a TBI, a traumatic brain injury, can absolutely cause permanent damage like that. It really depends on the type of injury. And then the way that they're talking here with the subdural hematoma, that can absolutely, again, cause, long-term issues like that. So traumatic brain injuries are really interesting because it could be something like, oh, I got a concussion because I fell off my bicycle and I'm fine a few days later. Or it could be something like, okay, I had a traumatic brain injury and now, 5 years later, I'm still having these sorts of issues. So it could really go any direction there. We do know that she had an injury. We know that it came before the symptoms. We know that it came before some of these other behaviors. And so it's likely then that all of these are being caused by the brain injury just because of the timing of the thing, right? If she didn't have any symptoms before the injury, and then she has the injury and she starts having symptoms, then it's likely because of the injury. And again, we always need, as with any kind of brain injury, and this is something, we talked a little bit about in class last week, because, traumatic brain injuries are such a hot topic right now. And the big piece is knowing what happened before versus what happened after. So it looks with Beatrice that most of these things started after the injury. So that would be probably the most likely. Someone also put delirium. You could also put a delirium here based on when she presents in the ER. So that would be, if you are the ER person and she's presenting with those issues, you could absolutely put delirium because that is what is happening right in the moment when you are diagnosing her. If you're the person who's diagnosing her later and getting more specific, then you would probably go with the traumatic brain injury, if that makes sense. Bridget Jones. Oh no. Let's talk about Bridget here.
So this one, I kind of had the same question because it seems like she has delirium, but the reason for the delirium is systemic lupus erythematosus. I don't know how to say that. So if I'm right, would you have to find a code for lupus? And if that's true, I couldn't find one.
So lupus would be something that would be medically diagnosed. And then, you're not going to find a code for it in the DSM. You'd have to look in the ICD. And you would initially code the lupus and then whatever the diagnosis is. This one, however, is a little bit tricky, right? Because we're seeing, so if you are, and again, it depends on your role. If you're the ER person, you're probably going to diagnose a delirium because that is what she is presenting to the ER with. You might also add a catatonia diagnosis because the rigidity, the mutism, being unresponsive, the facial grimacing, all of that. And then over time, let's say you're the person who's working with her long-term, then, since the delirium has gone away, we see that there is an issue here with the lupus, and it looks like there's something happening with the central nervous system. The things that are going to throw you off are the ECT, because that would indicate, these other issues, right? Often ECT is used to treat really serious depression, all of those kinds of things. So we sort of want to consider that information, but because we know after this lumbar puncture that it's due to the central nervous system involvement with the lupus, you could put first diagnosis, lupus, second diagnosis, major neurocognitive disorder due to lupus. Now, because lupus isn't in the DSM, the answer that most people put when they submitted it was major neurocognitive disorder due to another medical condition. Just because, you're not expected to know every single medical condition, every single ICD code for all the medical conditions. That would not be reasonable. If you want the extra mile and looked it up, good for you. But you certainly are not expected to. So yeah, the delirium would have been acceptable. Again, just depending on where you're diagnosing, and then long-term would be the major neurocognitive due to.
Hey, Liz.
Mhm.
I feel a little bit more confused now after we're going over all of these. I'm just wondering, because I know that when we mentioned before, like you had talked about like the table in the DSM, but I didn't find that to be as helpful. But I'm just wondering, like, if there's nobody at school today because of the snow. So it's like crazy in my house.
Yeah.
But I was just curious, in like the thought of like even kind of like creating your own of like ways in which like you are easily able to maybe distinguish between some or all of these, or like if I don't know, there's a lot of gray area, it feels like, and there's a lot, and maybe it's just the case studies also have like a lot of extra information and stuff that can kind of like confuse it too, but just like making sure that like we have like a really strong understanding of like, okay, these are like the main red flags to like be aware of with this condition. I just feel like a little, I thought I like had this one and I feel like I did them all wrong. So now I'm like feeling really confused.
Yeah, no, totally. And honestly, they are written in ways that are meant to be confusing. So that's not just you. And they are very, very subjective, right? When you get a case study like this and you have this whole history, the diagnosis is going to change, right? So some things that are a little bit, and neurocognitive disorder is not very black and white either. There's a lot of gray areas. Some things that distinguish, say, major versus mild are things like ADLs, right? Can the person do things like feed themselves, go to the bathroom, all that stuff? With Bridget here, we see that she can't at one point, and then later by day 90, she can. And so at that point, you might change it from a major to a mild. If they are having trouble with things like IADLs, like maybe they can do things mostly on their own, like they can do all of their ADLs themselves, they can feed themselves, they can change themselves, they can bathe themselves. I'm not counting things like physical limitations, but mentally they're able to do those things. That would be a mild. And then when it comes to the actual cause, realistically in the field, you will not be the person typically putting the cause, right? Unless you know for sure. And that was one of the other things in these case studies, the way that Dr. Sweeney wrote them was very purposely to not include the causes, because he wanted to get you sort of thinking about what could be the cause, right? The probable versus the possible, all that kind of stuff. This one specifically, it makes most sense to go with another medical condition since lupus isn't listed as one of the common issues in the DSM. So with these, it's mostly important to just stick to what you know for sure and then ask all the other questions. It's okay to not know for sure. That's the other piece, is that there are going to be times where you don't know for sure, and that's totally fine, right? Some people might read this and say, oh, well, she responded to antipsychotic. That must mean it's psychosis. Somebody could maybe make that argument. It's probably unlikely, much less likely now that we see all of these other issues happening, and we don't know for sure. So you really want to go just by what you see. And so again, depending on when you diagnose this person, when she comes in, we would go with delirium. At this 3-week mark, we're probably going to go with a major neurocognitive. And then by that 90-day mark, we would go with a mild neurocognitive, because her presentation has changed. And those are the only things we really know for sure. As far as, in general, the things to look out for, the ADLs, the IADLs, the amount of help the person needs to manage those things. And then, the additional cognitive pieces, if they are disoriented, if they are unable to know where they are, if they don't know what year it is, those kinds of things. I did put up some screening tools for folks to take a look at. Those aren't, those are just some additional material. They won't be on your exam or anything, but you can look at those and see the kinds of things that we're looking for when we're looking at neurocognitive disorder. So the sorts of questions that are being asked, right? Do you know what year it is? Do you know who the president is? Can you draw a clock? Do you know the different animals? Can you repeat back 3 words that I told you? All of those sorts of things are the kinds of questions we would take to see if someone's really oriented or not. So I would take a look at those too, just because they make it a little, those are sort of the standard mental status exams that are used in most settings. And so you can take a look at those and see what sorts of things we're looking for when we talk about the cognitive deficits piece.
Liz, can I ask one more question about this Bridget Jones? So since we all kind of seem to agree that when she first comes in, she's exhibiting symptoms of delirium, at what point do you decide, well, it's really not delirium? Because like for me, and it may have been a rabbit trail, I saw that she wasn't responding to the antipsychotic medication, which made me think, okay, well, the medication that's supposed to treat delirium doesn't work for her, so it must be something else. Was it a rabbit trail, or is that also when you decided it's not delirium, it's neurocognitive?
Well, here's the thing. Delirium can be a sign of neurocognitive. So I wouldn't say it wasn't delirium at the time.
See, I'm so confused.
Yeah, exactly.
Okay.
Right. It is very confusing. And not everybody with delirium gets treated. Antipsychotics aren't always effective. So let's say they have delirium because of like toxicity, an antipsychotic isn't going to work. Or a delirium due to, they've drank too much water or an infection, things like that. An antipsychotic isn't always going to work until you treat the underlying medical condition.
Okay.
And
See, I
so,
thought she had delirium because of inflammation caused by lupus.
well, that's what we think.
But I don't know.
Yeah. When she comes in, I would say she definitely has delirium, right? Because it happened very quickly over a few days. She was extremely disoriented. She started to have these paranoia type things. So don't necessarily worry about the medication piece. We're just describing the behavior and the cognitions. So when she comes in, I would say, yes, she does have delirium. And then over time, as we see the delirium kind of go away, then we just change how we're categorizing it. Like we're like, okay, she's no longer acutely delirious. However, she's continuing to have all these cognitive issues, this catatonia, all these other things. That's when we're going to change it to a neurocognitive disorder. And to further muddle things, let's say we already knew Bridget. Let's say this is not Bridget's first time experiencing delirium. Let's say that Bridget has had some of these issues for a very, very long time, because we don't have a great history there. We know about what happened right before she got to the hospital. But let's say we've been treating Bridget for a long time and we know that she already has neurocognitive disorder. Then when she comes to the hospital, we would say delirium due to neurocognitive disorder, all of that. So you really want to look at it as kind of like a cross-sectional point in time, what's going on right now. Yeah, these are not, it would definitely make it easier with these if it was said somewhere, when you're seeing the client or the patient, because then you would know right now that's what's happening.
Can you speak to how to there was something about with or without behavioral disturbance? How would you put that, and what signs would be behavioral disturbance?
So that's another very subjective one. A behavioral disturbance is really anything that's going to necessitate some sort of staff intervention. So here, the physical restraint thing, we don't know what she needed physical restraint for. If it was something like self-harm or lashing out toward others, maybe that would be a behavioral disturbance. The other things, I don't know that she would necessarily have a behavioral disturbance, because it doesn't say the running out of the streets in a state of agitation. Yes, but it looks like that was a one-time thing. If that was ongoing, then I would put a behavioral disturbance. On the other hand, our gentleman up here, he's doing things pretty regularly. He has started to physically threaten his wife. It sounds like that's happening more than once. He's turning up the temperature, he's turning on the stove, basically trying to set the house on fire. all of those kinds of things, exposing himself to neighbors, becoming sexually aggressive. There's multiple behaviors and they're happening more than once. And so then I would say that this is an ongoing, with behavioral disturbance. And then with Bridget, it would depend, how often is she getting physically restrained and why? We don't have enough information there. If it's due to, we have to do the IV feeding and she's catatonic, so we have to hold her down because of the catatonia, that's very, very different than she's fighting and we have to hold her down because she's fighting and potentially injuring people. Let's talk about Robin.
I put probable frontotemporal neurocognitive disorder because of the asymmetrical temporal lobe atrophy.
Mm-hmm.
And there was no genetic mutation. And then the stealing and the compulsive behavior, the disinhibition with the stealing and then the compulsive behavior, combing the beach. That's why I did that.
Yeah, so this one was a little bit more cut and dry than the others. We know for sure that there's an injury. We know where the injury is. We know that he's having these issues here with disinhibition, impulsive behavior, those sorts of things. So yeah, all of those. The other thing was the issues with recognizing faces, all those kinds of things. Some people did put a mild neurocognitive disorder instead of a major, which could be, you could make that argument because we don't have a lot of information here on ADLs. We see lots of behavioral stuff. We see some issues here with memory. And, it doesn't say whether or not, he's able to take care of himself otherwise. So you could go with major or a mild there. Either one of those would be acceptable. Let's see. Any other ideas, thoughts, concerns for Robin?
I thought he might have Parkinson's disease because of the swallowing issue.
Yeah. My hope would be that somebody would look into that, right? Because that's problematic. He's having these issues with swallowing and then he dies 6 months later. What does that mean? Did he have a Parkinson's that was undiagnosed? We don't know. So if this was my client, I would probably refer him for further testing. We don't have enough information the way that it's written to diagnose it, but yeah, I would definitely want to know more about that.
I had a question about the term semantic dementia.
Okay.
Because I did some research on that and I found it's used a lot in research articles and infographics for this diagnosis, but it's not in the DSM-5. So is that just something doctors use to describe it to patients?
Absolutely. Most people know the phrase dementia or the term dementia. Not very many people know the phrase neurocognitive disorder. So we want to use dementia, neurocognitive disorder basically interchangeably. And a big piece of that is the DSM decided to change it to neurocognitive disorder because when we hear the word dementia, it brings to mind specifically things like Alzheimer's, older adults, that kind of thing, as opposed to neurocognitive disorder, which encompasses all of these other issues that can happen at various ages, that can happen, due to a stroke, all of those kinds of things. So the terms are pretty much interchangeable. And you'll see dementia still show up more in the medical field. And then depending on if they do an ICD or DSM diagnosis. The main difference is because us as mental health practitioners, we're going to be diagnosing neurocognitive because what we're measuring is the cognitive piece. What we're diagnosing based off of is the cognition and the behavior. And so we're always going to go with neurocognitive, but be aware that a lot of doctors are going to say dementia instead, but it really could mean the same thing. Alrighty, let's talk about all the things. So adjustment disorders, like I said, we had reviewed these a long time ago when we talked about trauma and anxiety. However, they are listed on your syllabus as part of today's material. So I want to review them quickly because they could show up on your exam. The other reason that we're going to talk about them is because a lot of the other, other clinical issues listed in the DSM for this section, we want to be able to rule out adjustment disorders. And so we'll get to that today, kind of later on in the lecture after break. So, anybody have any questions about adjustment disorder from way back? So again, we're seeing some sort of behavioral disturbance as a result of some kind of stressor or life change that is out of proportion with severity and intensity of the stressor. And it is going on for a long period of time. So this isn't the same as, say, an acute stress disorder. Thoughts, questions, concerns, feelings, etc. So differential diagnosis. Any other episodic types of diagnoses. So let's say somebody has a major depressive disorder and they, the stressor induces an episode. If it turns into PTSD, or we see additional PTSD symptoms like the hypervigilance, the nightmares, all that kind of stuff. Personality disorder, and they have an episode that is brought on by the stressor. We want to differentiate this from normative stress reactions. And that's what we're going to talk about today, is all the coding for sort of life circumstances that cause normal stress reactions, right? Things like abuse, history of trauma that doesn't necessarily cause PTSD, all that kind of stuff. When we're coding adjustment disorders, we're going to specify what it looks like. So are they depressed? Are they anxious? Are they anxious and depressed? Are they anxious, depressed, and acting out? All of those kinds of things. So now we are going to move on to the end of the DSM. Yay. And look at all of these other diagnoses that basically say, hey, something's wrong with this person, but we don't know what, or this person is presenting with symptoms, or they're having issues, or they are stressed out, they are experiencing clinical distress, but they don't necessarily meet full criteria for any other diagnosis. So with this one, other specified mental disorder due to another medical condition, you can pretty much add whatever specifier that you want here. So if they are dissociative, put that. If they are having depressive symptoms, put that. If they are having a speech problem, put that. If it is causing problems with peers, problems with family, not adherence to medical treatment, any specifier you can come up with, you can put that here. So what's happening with other specified mental disorder due to another medical condition? The person has some kind of medical condition and it is causing some sort of symptoms. The key here is to make sure that it is not, again, an exaggeration of an existing mental disorder. So the example they give you in the book is seizures. We know that seizures can cause depressive-like symptoms, but we would also want to make sure the person doesn't already have depression in addition to that. If they did, you would put both. What really makes the difference here is if the symptoms are due entirely to the medical condition or if they exist as a standalone diagnosis. Here we see the example they give is dissociative type, which basically means, okay, when this person has some kind of seizures, they also experience dissociation. It doesn't say that they co-occur all the time. It could mean that as a result of their seizures, they are experiencing dissociative episodes. The reason we would use the other specified mental disorder due to another medical condition is because dissociative symptoms are the only symptoms this person is having. If they were having other symptoms, then we might look at a different diagnosis, right? We might look at like depersonalization, derealization. We might look at something like dissociative identity if they had all of those other symptoms and met criteria. But because it's only due to the seizures and because it's the only symptoms, this is the diagnosis we would use. So things are getting more and more sort of complicated here.
Can I ask one question? So in that example, you have the complex partial seizures first because it's the medical thing. And then below that, you have the specified mental disorders. When we're writing it up, do we stack them like that? Or do you put a comma? Like, does it not matter? Is there a way to do it?
It really doesn't matter. The nomenclature is just going to depend on the type of documentation that you're doing. So when you're looking at somebody's chart, you're going to usually see them listed one per line. And then when you're writing notes, a lot of times you'll see them, you know, diagnosis, comma, diagnosis, comma, diagnosis, comma. Some people use semicolons. It just depends on the type of documentation. It would be great if there was a standard way to do that. But it just depends. So like a patient's face sheet, it's going to have them listed line-wise. But if you're writing progress notes, it might not, unless your agency uses some sort of specific format where they have them listed. If you're a psychiatrist, you're probably going to list each one and then the current evidence for each one. So it's really the best way that you want to conceptualize it. For purposes of this class, I would expect you just to list them out however you want, and then, you know, followed by your rollouts.
Okay, that's helpful. Thank you.
Yeah, that's the only thing that's really standard is the current diagnoses, past diagnoses, and then rollouts. Unspecified. So here, very similar, and this shouldn't be here. We are choosing not to specify the types of or symptoms that are happening. And in the DSM, the example it gives includes dissociative type. So what would be the reason then for using unspecified if it says right here what the type is versus specified where we are definitely adding a specifier there? Any thoughts? These are tricky.
Maybe waiting on diagnoses, or maybe you're waiting on a radiologist reading something or the doctor reading.
Yeah, we could be waiting for more testing. We could be waiting to see how often is this person experiencing the dissociative type. The main difference here is that you can put a specifier, but you don't have to. Whereas with specified, being the key word, you need to put a specifier because it's a specified mental disorder. Here, because it's unspecified, you don't actually need to put this dissociative type piece. If you think that's what's happening, then for sure, put it, but you don't have to because it's unspecified. And last but not least, this is something that we use if we know that this person is having some kind of mental health issue, but it doesn't meet any other criteria. The other specified mental disorder, this is really useful for things that aren't currently in the DSM, right? So let's say the person has some kind of addiction that isn't listed in the DSM. If they have, you've probably heard the phrase sensory processing disorder, not in the DSM, orthorexia, not in the DSM, all those kinds of things. You might even put here, I know when we talked about the somatic illnesses, let's say the person has, you know, like muscle dysphoria, but they don't meet the full criteria for one of those diagnoses. You could put something like that here. So basically any diagnosis where you have specific things happening, right? So again, there's that specifier piece, but it's not in the DSM elsewhere, or it is, but they don't meet full criteria. Now, why would you do this, say, as opposed to like an other specified depressive disorder or an other specified somatic symptom disorder? Or like with orthorexia and other specified eating disorder, what would be the reason for choosing just an other specified mental disorder?
Maybe if DSM is updated, then that might give a clue to the next person to look there first.
Yeah, absolutely. Right. So you're communicating that there's going to be some kind of change.
I mean, I might feel like I don't have enough information to designate something else, but there's enough evidence that something's going on, but not enough to actually designate an addiction or something like that.
Yeah, absolutely. And these tend to be really subjective, right? Like, how would we objectively measure something like internet addiction? We have ways of objectively measuring gambling addiction. We have ways of objectively measuring substance use addictions. If you felt like it doesn't, that internet addiction doesn't necessarily meet the same sort of criteria, because culturally, people are on the internet all day, every day, then yeah, that makes sense, right? It doesn't really meet the regular definition for addiction, because we're not looking at things like they need more and more to get the same stimulation, stuff like that. The other piece for this would be, let's say they have symptoms from various other diagnoses. So let's say there is let's go with orthorexia, for instance. Let's say they have this obsession with certain types of food, clean eating and all that kind of thing. And then they also have some, obsessive thoughts about it, some compulsive behaviors, but again, not enough that they would meet OCD criteria. It's only about the food, so they don't meet OC personality disorder. Let's say they also have some behavioral issues as a result, like they have outbursts, or maybe they have some sensory issues about certain types of food, or they get really, really angry, and lash out at people, or it's because they have these issues with abandonment or other relational issues. So those are all things that could be considered symptoms of other diagnoses, not just eating disorders. And so I would then list it as an other specified mental disorder, orthorexia, with behavioral disturbance, with relational disturbances, as opposed to listing, every single one of those other diagnoses that it doesn't meet qualifications for. Because if we were to put, other specified eating disorder, it wouldn't really account for all those other sorts of issues. Savannah, you have your hand up?
Yeah, so just so I understand clearly, so what would the deciding factor simply be the number of symptom categories that are present, or is it more kind of based on the degree to which they could fit the, because if you had dissociative unspecified or other specified, and then you had the eating disorder other specified, then would it just matter how many of the symptoms that each one ticks, or is it just simply how many of those categories do we have?
Really the first one. So let's say you had somebody that had 4 out of 10 symptoms, but to get that diagnosis, it would require 6 out of 10, right? That's where you might put something like an other specified, depressive disorder, PTSD, whatever it is. But let's say they only have 2 out of 10. And you don't think it's really, it's not like you think that this thing is developing, but they're coming to you because they're distressed by those 2 out of 10. Then you would use, the other specified. Let's say you have somebody that has 1 symptom from every single diagnosis in the DSM. Probably not likely, but hypothetically, that's where you would use another specified. What it really comes down to is what the person's chief complaint is. So if they're coming in because they subjectively feel like they have this issue and it's a specific issue, but it doesn't meet any other criteria, that's when you would use this. As opposed to further muddy the waters, unspecified. So this is really where you just don't have enough information. You're like, something's up with this person. They're coming to me and they have these complaints, but their complaints don't really match anything else in the DSM. I've actually never seen this diagnosed, but that's also because all the settings that I've worked in have required, they're typically folks that have something like schizophrenia. You might see this more in outpatient, but yeah, I've never actually seen it diagnosed, but you might see it more in, less acute settings. It could also be something, let's say you're working in the ER and this person is coming in and they clearly have some mental health things going on, but maybe they're not communicating well enough to really demonstrate what those things are. Maybe their behavior isn't clear enough to demonstrate, what exactly the disturbance is. You don't know if it's psychosis. You don't know if it's delirium. You don't know if they are having a really, really bad depressive episode. You don't know if they're having a really, really bad manic episode. You can't tell just based off the behavior alone or what the person's telling you alone. That's when you might put an unspecified. But again, for most of you in your settings, that would not be very common because, you're all pretty good at looking at people's behavior and fitting it into a different category. You've done that with the case studies so far. So it really not common, but, keep an eye out for it.
Would you ever use this as a way to protect your client's privacy, or would that be considered unethical?
That kind of depends on your personal ethics. So let's say you are working with somebody who is in some kind of unsafe situation. Absolutely. Right. This comes up a lot if you're working with adolescents, especially because you're not going to diagnose, like when we get to the second part of today, which I think we're actually going to do first, just because it makes more sense. That's what we're talking about. I'm not going to list a diagnosis like problem with primary caregivers or suspected abuse with primary caregivers if my kiddo is living with those parents and they're looking at the kid's chart. Right? You have to think about those sorts of things. Like, okay, are they then going to pull this kid out of therapy? All of those sorts of ethical issues. It could also be something that you put because you just don't know what's going on yet, or you're really still learning to, the person. Let's say you have a client who is coming in and they don't have a specific chief complaint, and you're doing the assessment, and the assessment takes 3 or 4 sessions. You might need to put something down while you're doing the assessment. It doesn't happen often because usually if people are coming to therapy, they're coming for a reason. They're going to tell you like, I'm just not myself. I feel down. They're going to say things that fit into something else like depression or anxiety or, other issues, but it could happen. Yeah, I'm going to do the second half of today since we're already kind of discussing other types of coding. So, other conditions that may be a focus of clinical attention. These would have been really, really helpful. And the reason we're doing them at the end is to kind of show you that you can add things that you don't consider to be relevant necessarily to the diagnosis. However, warrant clinical attention. So, like in some of the case studies today, you might say, problems with spouse, problems with family, problems with work, stuff like that. And even though it could, it might be part of the other diagnosis, but it is a standalone issue, and that's what that person wants to talk about. These could also be things that you're just discussing that visit. So let's say the person is coming in, they meet full criteria for, say, depression, persistent depressive disorder, major depressive disorder, but what they're really, really struggling with primarily is issues with work. You're going to add that. You're going to add that as its kind of standalone thing. Now, these are not really disorders. And so I wouldn't categorize them as like, oh, there's something wrong with this person. It's usually just a way of describing what's happening for the person. So that will make more sense as we go through them. Problems related to family, right? So parent-child relational problem. I've never worked with an adolescent that doesn't have issues with their parents because they're teenagers and that's what they do, right? That is not a disorder. However, if that's what they're coming to therapy for, or they are just wanting to learn how to communicate more, all that kind of stuff, I'm going to put in a parent-child relational problem. Let's say you've got a kiddo coming in because the parents are fighting or the parents are getting a divorce. Most kids are going to struggle, right? And here's where we'd want to roll out adjustment disorder. So they don't meet full criteria for adjustment disorder, but maybe they just need to talk about it, or they're just struggling with it in some other way. I'm going to put child affected by parental relationship distress. Upbringing away from parents. So this could be things like you're working in an agency that works mostly with foster kids and they are just struggling with that. And again, they're not meeting full criteria for adjustment disorder, although if this was the main thing, right? If you wanted to say something like major depressive disorder and then list this as a separate problem, or if you just want to describe the person's history, you could use these as add-ons as well. But it can be a standalone, it can be an add-on, all that kind of stuff. Sibling relational problem, same thing. They're just having issues, right? Or it's related to. You could add it on, or you could do it as a standalone thing. I use these a lot with family therapy. Let's say you have to put something for every single client. Not common, but depending on the insurance, you might have to. Let's say there's one client in the family that is clearly the entire problem, but you got to list something for everyone, right? I'm probably going to put a sibling relational problem for all the other siblings, something like that. I might also use it in cases where, let's say, their main diagnosis, you know, it's there, they meet all the criteria, but this is their chief complaint. So if I have a client who's dealing really, you know, has generalized anxiety disorder, and one of the main contributors to that is their siblings or their parents, I might add something like this. Or like I have a client right now, it's a little boy. I think I've mentioned him before. He has no issues. The family's convinced that he has issues, but it's because they're the type of parents that think that their kids have issues all the time. This family took him to every single doctor in town to get him an ADHD diagnosis, and nobody would do it because they're like, he's just a normal little boy. Mom has some anxiety issues, but there is a genuine, sister has a pretty severe autoimmune disorder. And, you know, as a result, there's some discord in the family, and the brother's really struggling with things like feeling like sister gets everything she wants because she's sick, all that kind of stuff. That's not a mental disorder. That is a normative reaction to being in that kind of family dynamic. But because he's coming to therapy, or the parents are sending him to therapy, you know, I list that as a sibling relational problem because he's not getting along with her. And we're not putting any sort of moral judgment here, right? We're not saying it's right or wrong. We're simply describing that that's what's happening. Abuse and neglect. These get a little bit more serious. So I want to point out before we go into these that obviously these can be pretty triggering for folks. So if you feel like you need to step away, feel free. They're also a little bit contentious because these are the clinical definitions, right? These are the clinical definitions that, you know, the APA has decided upon. So they are not legal definitions. And they might not be the same definitions that we use culturally. So when we describe things or we define things like abuse, you want to keep in mind that these are not how we might define it legally. Like if you're a DA and you're prosecuting the parent, and it might not be something that you agree with culturally. So just keep that in mind. So with the child abuse, this is physical abuse, non-accidental physical injury, regardless of whether or not the person meant to harm the child. Sounds a little contradictory because you're saying on one hand it's non-accidental. The next part is regardless of whether or not the person meant to hurt the child. So non-accidental means I hit my kid on purpose. I meant to hit them, but maybe I didn't mean to hurt them as badly as I did. So do you see the distinction there? Or a person is angry, they grab the kid by the arm, and then that part is the non-accidental, but maybe it left a bigger bruise than they thought that it would. So the way that we are trained is that, you know, we try to be very culturally aware of different discipline techniques when it comes to things like spanking. However, the clinical definition that we're going with is that if it's hard enough to leave a mark, whether it's a bruise or a red spot or whatever, that is when it crosses the line into physical abuse. You'll have a lot of folks that will argue with that, right? I had a neighbor who I'm like, oh God, like, what are you thinking? Who showed me a photo of her child's buttocks unclothed with a big handprint on it. And she's like, they're saying that I abused my kid, but it's so clearly that I just spanked them and you're a social worker. And I'm like, oh, okay. Well, first, red flag is you're showing somebody who's basically a stranger a photo of your nude child. So that's not a good sign. Second, if it's hard enough to leave a bruise, then yes, that is why there's outside involvement. And please don't ask me for my opinion because I'm your neighbor and I don't want to I haven't seen or heard anything. If I do, then, that's going to be an issue because that's reportable. Yeah, whole thing is weird. So these are things that you will see, depending on the system that you work in, fairly common. And the way that these are coded are really aimed toward working within the child welfare system. So somebody let's say, or in the medical system. So let's say you are working at a doctor's office, kid comes in, they've got bruises. The parent tells you, yeah, I hit my kid, and that's where those bruises came from. You're going to use the confirmed. The initial encounter and subsequent encounter really depend on, again, when you're seeing the kid. So if it's the first time they've come in and this is when you're doing that assessment and this is when you're reporting it, because if you're listing one of these diagnoses, you have to, as a mandatory reporter, you would best be reporting it. If it's suspected, so let's say the kiddo comes in and they've got handprint bruises all over them or just any kind of bruising or whatever, and you believe that it's because the parent did something, but they either don't tell you or they deny it, that's when you would use suspected. These are coded the way that they are, again, for the settings, but also because they want folks to be really, really careful with, this is the first time we're noticing it versus this is the third or fourth time we're noticing it. And again, each time you need to be reporting that. Other circumstances. So these are, let's say you work in child welfare, doctor's office or whatever, and you are meeting with the kiddo, meeting with the parent. Let's say you are working in some kind of intervention program where you are doing treatment for the parent. That's when you would use the encounter for mental health services for perpetrator. If you work in any kind of incarceration setting, stuff like that. You would also use these for assessments, right? So maybe this person isn't your regular client, but you work at a victim center. So you're going to be doing an assessment for each person that comes in. Then I'm going to call that, and I'm going to call that an encounter, right? Anytime you meet with a client, that's an encounter. Other things here, this one here, I use this a lot in my work because as a trauma therapist, I have lots of folks who are adults maybe, but they're telling me that they were abused as children. And so I add this just because it adds more to the picture. Or let's say, this is especially frustrating as a trauma therapist. Let's say they don't meet full criteria for PTSD, but they're telling me, I have these things that I want to sort through, I want to cope with. And so I use a code like this that says this person is reporting to me that they were abused as a child. You might also use that for children. Let's say you're working with a kiddo that's no longer in their family of origin because of abuse. You might add that personal history code because, again, it's adding to the full clinical picture. Child sexual abuse. So this is something that the DSM does a pretty good job of being very inclusive with. If you work at all in the trauma field, you will often see this abbreviated as CSA. You'll hear that used interchangeably instead of just saying, child sexual abuse every time. So this is any act, physical or non-physical, so contact or non-contact, regarding anything for someone else's sexual gratification. So obviously this is going to include all of the physical acts, touching, penetration, all that kind of stuff, indecent exposure, all of that. And then the non-contact piece. So this is where things get a little tricky. And this is where a lot of clients don't do, they're not sure if they've experienced sex abuse or not, but they feel like they did, right? Like I have a client right now who very specifically remembers that his mother would expose herself to him, but in ways that were not to him clearly sexual abuse, even though, now later in life, he's an older adult, now later in life is having these really clear memories of like, hey, this was weird. So basically what would happen, mom would be taking a bath and she would call him into the room and sort of emerge herself from the water and show herself to him as a little boy and just ask for like random things that she didn't actually need. And this would happen over and over. And he felt very much at the time like this isn't normal. Other children aren't hanging out with their mom while they take a bath. And he was, older at the time, like 11, 12, 13. This isn't like a toddler and you're taking a bath together, but he had these memories of feeling like she was trying to expose herself to him sexually or excite him sexually, but he wasn't sure, like, can I call that abuse or not? if she never actually touched me or she never actually said that it was sexual. And I'm like, well, if now 60 years later, you're remembering it and you're remembering that it made you uncomfortable, then absolutely, I would call that child sex abuse. So use your clinical judgment. Look at how it's affecting the person, all that kind of stuff. Your actual codes here are very similar to physical abuse. So if it's confirmed versus suspected, if it's the first time you're meeting that person, or if it's the, additional times. Definitely be careful with when you code these, because these are the sorts of things that do come up in like child welfare cases and that sort of stuff. So you want to make sure like, okay, this is the first time we're assessing this kiddo for abuse versus, okay, it's their third, fourth, fifth time for therapy, just, to address that or to monitor it. Additional codes. Also,
I have a quick question.
Mhm.
Is that the first time that you've diagnosed it, or is it the first time ever? And so like when you're coding that for initial encounter, is that like if you're aware of previous things, you would put a subsequent encounter, or if it's just the first time you?
It's the first time you do it. So this is your initial encounter with that client. If you know it's already happened, then that would be confirmed. If it's the first time and you don't know for sure, then it would be suspected. But either way, you're going off the first time that you are meeting with the client.
Thank you.
Mm-hmm. Additional coding here, again, very, very similar to the physical abuse. So personal history, we use that a lot. Because we don't have, a CPTSD diagnosis yet. And so we have lots of folks who will, report these things to you and they want to talk about it. And maybe they don't have a mental health diagnosis, but they still have this thing that they want to process. Savannah, you have your hand raised, it looks like.
Sorry.
You're fine.
I guess what I'm wondering is the line between suspected and confirmed, because if the child clearly says, yes, this has happened, then that would be confirmed. But what if to me, it would be really obvious, but nobody has actually said it, I guess, if that's possible, if there would be a situation like that.
Yeah, absolutely. So you would still put suspected. And it depends on your job, right? If you are in, if you're the social worker or the client or the clinician or the therapist at the doctor's office and you don't know for sure, you're going to put suspected. But if you're the person whose job it is to go and actually assess for it, then you're going to, there's going to be specific questionnaires and things like that you use. So let's say you work for DHS or you work for some kind of victims program, things like that. They're going to have specific questionnaires and specific things that you're supposed to look for when you go and do those home visits and whatever else. But for like outpatient thing, those sorts of settings, you might know, you might have the gut feeling that something here is happening, but until you know for sure, either they've told you, it's been reported, confirmed by, one of those people going to the home or doing the assessment or whatever, you would go with suspected. Either way, you're reporting it, right?
Right.
Unless, of course, you're the person who gets the reports, in which case, it's kind of a moot point, but.
Okay, so like in that position, you would need verbal confirmation to.
Or other kinds of evidence, right? Because sometimes these things, especially if it's a little kid and they don't have words for it, this would be the whole like, okay, show me where they touched you on the doll. And if they show you, then I would call that confirmed. But I'm also one of those like better safe than sorry types of people, just because of the settings where I have worked. So
I have a question here about scope of our practice. When it comes to children reporting sex abuse, aren't we supposed to refer these on to the specialists who have the training? For example, dolls are not used with children anymore because they led to wrong answers. And so when we have a child come to us, as soon as they say this, aren't we supposed to refer and stop all questioning so that they are sent to the specialists who will be able to get the information to protect them and to prosecute the person who's doing it?
Yeah, if you're an outpatient, yes, absolutely. But you could be, based on your degree, you could end up being the specialist.
Right.
Yeah, and so that's why we're going over those. Yeah. And again, it just depends on your role. So if you are working in a doctor's office, for instance, you're not going to ask questions that would lead to, say, prosecution, because again, we're not using legal definitions here. We're just using clinical definitions. And all of the, you're not going to give the child a formal interview. For instance, the whole doll thing, like that is not going to be within your scope. And like you said, we don't necessarily use those anymore. I was using that more as kind of an illustrative example of like a kid that's pre-verbal. But if you are, so let's say you work in a doctor's office and you've got a kiddo coming in and they have repeated infections and their behavior is such that it indicates suspected abuse, you would definitely put down, initial encounter for suspected. You're always going to report it no matter what. But even if you are not the one doing the forensic interview or the full assessment, you're still allowed to ask questions for clinical purposes. If you are the mental health treatment person, for instance, you might be doing some kind of trauma work. And let's say part of that trauma work is verbal processing, or let's say you're doing EMDR or some other kind of narrative type of work where you are going to be verbally discussing those things. You can absolutely ask those sorts of questions because it's part of the treatment, with the caveat that, yeah, you might get subpoenaed. And again, because we're going with the clinical definitions and not the legal definitions, that's what you're assessing for, is how is this clinically affecting this person? As a clinician, would you say this person is being abused? If you do end up in the kind of job where you're doing the formal assessments, or you're working for DHS, or you're working for a DA's office or that kind of thing, then you're going to be trained on all of those separately. This is just the clinical side. Does that make sense? Yeah, it's not a great position to be in. It's a really, really icky position to be in. And, it's one of the things that we kind of sign up for when we go into this work. Coding here. So I think we talked about these. Same thing. This would just be, this is what I'm seeing that person for today. Neglect. So again, these are not the legal definitions. These are the clinical definitions. So someone's coming in, they're having these sorts of issues. You're going to report it to the folks who do those legal assessments, to the folks that do the, the DHS assessments, unless of course you're that person. But assuming that you're, a therapist or, outpatient or at a doctor's office, that kind of stuff, this is what you're looking for. Things here do get a little bit sticky, and there's a very long history of, the child welfare system treating different types of families differently, right? And so there is going to be some subjective stuff here. So let's say the kiddo's coming in, they don't have clean clothes, maybe the water has been turned off in the home, that sort of thing. Am I going to report that kiddo for neglect? Or let's say that I find out that it's because the family doesn't have money, or maybe the family's homeless, or maybe they have a home, but the water's been turned off. Am I going to report that for neglect? Am I going to call that neglect? Those are the sorts of questions that are really, really important. And you will notice here that unlike the physical and sexual abuse, it doesn't say non-accidental, right? And so it is left up to you to decide that based on your ethics and what you think is most appropriate, right? To me, there's a big difference between a family that's homeless, but they're still taking care of their kid the best that they can, versus a family that's homeless and they don't care, right? Or the family that's had their water turned off, and they're still trying to, get their kid bathed, get their clothes washed, they're doing whatever they can, they're applying for assistance, all that kind of stuff, versus the parent who just doesn't care. Depending on your setting, you would need to consult with your team, right? You might consult with your supervisor, you might consult with your peers and say, should I report this or not? That gets iffy. Yeah. A big piece of it, people are often afraid to report because they think that that means the kiddo is automatically going to be taken away from the family. That's often not the case. And it depends on your county. There are things to take into account there, right? We know that families of some races tend to get treated differently by the system. We know that impoverished families tend to get treated differently by the system. And so you really want to think about those things. And depending on your role, you know, if you are this person's therapist, you might want to help them get hooked up with some case management to get them the things that they need. You know, if the issue is just that their water got turned off, that's very, very different than I have a bathtub, but I'm refusing to let my child take a bath, right? So you definitely need to use your best clinical judgment here. With the caveat again that these are not legal definitions. These are, you know, what we're looking at clinically. So with that in mind, here are your codes that you would use, very, very similar to the physical and sexual abuse, whether it's the first time you're seeing them or if you've continued to see them. These are used a lot in like ER settings, for instance. If it's the fourth time the kid has showed up at the ER with, you know, a broken arm and you believe it's because of the parents, you're going to code that, right? And you're going to report it every single time. Because this, again, really shows, okay, this is the first time that's happened versus like this is the sixth time that this has happened.
Maybe we'll get to this, but what if it's the parent that you're seeing, but they report stuff that, you know, like they say things that make you suspect that kind of stuff?
I'm as a mandatory reporter, you would probably still call that in.
Would you code it in their paperwork at all?
Yeah, so that's where you would put here the encounter for mental health services for perpetrator.
Okay.
And some people think that they should only use that code if they're actually doing treatment for perpetrators, but I would use it anyway, just to be on the safe side. And again, it depends on your setting. If you're working in an ER and you're not actually doing treatment for abuse for the perpetrator, I would probably still put it. Either way, though, you're going to report it. Savannah, you have your hand up?
If you had, this is kind of going back to the abuse section, but I just thought of this question. If you have maybe a sibling who's abusing another sibling, and of course you'd have to report that, does the process look different because the parents are kind of, they're not doing it themselves, but do they have maybe culpability, or is there some kind of process that's specific to this situation?
So those are great questions. And those are more sort of in the legal realm of things. Clinically, there actually is a section down here on non-parent abuse or non-caregiver abuse. And so you would code it that way and then kind of leave it up to the legal folks to decide if the parents are culpable. Now, let's say if we get down here to psychological abuse, let's say one sibling is harming the other sibling and the parents are encouraging it, or, you know, getting the kid to do it in some way or another, then absolutely I would code that the child is a victim of both psychological abuse from the parent or caregiver, and then I would add the additional code for, you know, the non-parent, non-caregiver physical abuse or sexual abuse or whatever it is. So this is another one that, again, we're going with clinical definitions because these are the sorts of behaviors that we are going to clinically treat. These are not always legal definitions. So there are lots of people out there who are very, very psychologically abusive, who never get prosecuted because it doesn't meet the legal definition. So yes, you're going to report it, and legally, that gets really sticky, but you're still going to treat it because you are a clinician, right? You're not a DA, you're not the prosecutor, all that kind of stuff. So here's the way, lots of examples here, and this is not an exhaustive list, right? If you're working with somebody and they tell you that they feel like there's some sort of psychological abuse, or maybe they don't call it that, but they're talking to you about the way that the parent or caregiver is treating them, and that feels really icky to you, and they're talking about it in a way that is, you know, where they are clinically distressed, then you would still add this code. Couple of examples. Everybody has seen one or both of these films. Probably. Yeah. I have a client right now who is an adult. However, she is the only adopted child out in the family, and the parents like to do things like take the whole family to Disneyland except for her. stuff like that. And it's really distressing to her. And so I would call that, you know, having a personal history of psychological abuse, because this happened as a child as well. Yeah, I see some of you shaking your head. Pretty nasty stuff. Coding, same as always, first time I've seen them versus repeated. Additional coding. So these personal histories, you will use those a lot, especially with adult clients. And these are also useful, you know, let's say you have a client that has PTSD and you want to say why, you could add this personal history there. If you are in a setting where you're doing full psychosocial assessments, you can add a personal history code, just because, again, it tells, it helps paint the clinical picture. Because oftentimes in those settings, you'll say this person meets diagnostic criteria for PTSD, and then you'll have staff go, well, what do they have PTSD for, right? And then it can be useful to have those sorts of these codes in addition, because it might help explain that first diagnosis, even though you're not required to. It just depends, again, on your setting and what kind of clinical picture you're trying to paint for this person. And then while up here, we're saying, okay, I believe this person's being abused, and we're just doing the code for the encounter. Down here is where, you know, we would code and say that we're actually doing services, like victim services. Spouse or partner violence, physical. So similar here in that it's non-accidental, meaning that they meant to do the thing. They might not have meant for the person to get hurt as badly as they did, but they meant to do the thing. Again, lots of examples here, not an exhaustive list. This is where things get sticky. So once again, we are not going with legal definitions, we are going with clinical definitions. So if you believe that your clients did this thing in self-defense, it's up to you to decide how you want to code that, because you're not going with legal. You're not saying that this is an actual legal defense. You're just saying clinically, I don't believe my partner did this to hurt I don't believe my client did this to hurt their partner. That's all you're saying. You're just describing what happened. Within the last year piece, that is there only because you're going to code it as current versus personal history. You might also, I've seen people do this where it's technically not correct. Let's say it happened a year and 3 days ago, but they're still with the person. You know, I would probably still put personal history and then, you know, the date. Because I'm pedantic, but you could use your clinical judgment there. Coding here, same as the others, initial versus subsequent encounters. And then again, if you are doing the treatment for the victim, if they are reporting a history, and then if you are doing some sort of treatment for the perpetrator. And this could be anything from interviewing the perpetrator to doing the actual, you know, behavioral treatment, that kind of stuff. Spouse or partner violence, sexual. So, as with the other types of abuse codes, this is going to depend on that person's subjective experience. If they feel they were coerced, if they feel they were compelled, even though there are some states and some politicians who believe that it can't be a thing if it is spousal, or whether or not it was physically forced, clinically, because we are treating the psychological effects, it doesn't matter. So the DSM states specifically, it doesn't matter whether or not the act was completed, and it doesn't matter whether there was physical force. It can be physical force, but it doesn't have to. So again, going with the clinical definition and not the legal definition. If some of you go on to law school to become a prosecutor, that will look very, very different. But because you're a clinician, this is what you're helping the person out with, not whether or not they actually got charged and that kind of thing. Your documentation can be used as evidence, but you're still going to go with what you feel like that person is needing the most help with. Similar codes here. If you're working with an adult, say, and you suspect that there is spouse or partner violence, why would you put suspected and not confirmed? Or let's say, like, what are some examples when something like that might happen?
Maybe they alluded to something, but didn't specifically say something happened or wouldn't answer the question directly.
Yep, exactly. And this happens a lot because, and here's where things get also uncomfortable feeling, we are mandatory reporters for children. We are mandatory reporters for older adults. We are mandatory reporters for people with disabilities. We are not mandatory reporters for able-bodied adults, unless they're over 65. And so a lot of people, they don't know that, and they're afraid that somebody might get reported, or they're afraid that they might get hurt more. And so they're going to deny it. They're not going to be honest, all that sort of stuff. And so if you feel like that's what's happening, then code it. Same things here. If you're treating the person for being a victim, if they are reporting a past history of victimization, or if you are interviewing or treating the perpetrator. Where this gets interesting. So like at my job at the prison, for instance, I had lots and lots of clients who obviously were perpetrators. That's why they're at the prison. But let's say I'm treating them for their schizophrenia, but I'm not treating them. I'm not doing sex offender treatment. Not going to put this code because that is not what I'm treating them for. If I'm doing sex offender treatment, I'm absolutely going to put this code. Or let's say they are, and I actually got in trouble for this, and I kind of won because they tried to give me the legal argument. I'm like, no, clinically, this is what's happening, where I had a client disclose to me a past experience in which he perpetrated sexual violence. And so I coded it this way, in addition to the regular diagnosis. And I was told, no, don't do that because we could be held legally liable. And I'm like, not my problem. My problem is that's what this client wants to talk about. Yeah, in Oregon, we don't do sex offender treatment at the state level because this is fun. Most adult sex offender treatment programs result in about a 5% recidivism rate, which is still higher than we would like. Untreated sexual offenses have about a 20% recidivism rate. However, the state of Oregon has decided that the financial liability for civil suits for that 5% that might recidivate outweighs the harm or the potential harm to future victims for the untreated 20% recidivism. So that's nice. Those are the sorts of fun real world issues that you will encounter if you work in that system. Spouse or partner neglect. This is something you'll typically see if somebody is dependent, right? Why is this like this? So one partner has a disability, maybe they're older adults, but it can also be some sort of psychological dependence. Let's say that this is a partner who is completely dependent financially on the other partner, and they do things like don't let them buy food, that kind of stuff. Could also be cultural issues. So the person gets a spouse from a different country, speaks a different language, something like that, and they are therefore completely dependent, all those kinds of things. Codes here, and we see things like that, right? You know, older adult shows up at the ER and you notice that things are off, but they say, oh, I fell, right? And then the partner leaves the room and all of a sudden the story changes. Or maybe the story doesn't change, again, because of that fear of subsequent harm. You know, you would still code it the way that you feel is most appropriate.
Can I ask a question about reportability on that?
Mm-hmm.
if like you're in a situation where with abuse and there's a reason to think that if they went home, that they would then be abused, is that a mandatory report, or is that like, because if they said to us they were going to hurt somebody or themselves, then that's mandatory report. What if they thought that they were going to be hurt if they went home?
If they are an able-bodied adult, nope.
Okay.
If they are an older adult, age 65 or older in Oregon, that is, or if they have a disability, whether it's physical or intellectual, then yes. But if they are an able-bodied, able-minded adult, no. In fact, some people can even get in trouble for that because you're breaching confidentiality.
Okay.
So it's not a great position to be in. It does happen. And the reason for that, whether you agree with this or not, is, you know, let's say you do report it and the cops show up and that person, for whatever reason, they can't leave, right? Maybe they're stuck there financially, or they have other, you know, there's children involved, or another reason where they don't feel like they can leave that abusive partner, but now the cops show up and they get hurt more because the cops showed up, right? And then they come and they stop seeing their clinician because you reported it. What I've done in those situations is essentially helped the person find the resources that they need to get out safely. Our field is also a little bit behind in how we define making informed choices, right? So I've had lots of supervisors say, your client has the right to make bad choices. And I'm like, oh, is it really a choice if they feel like they don't have a choice? But that's sort of the, you know, the mantra. So yeah, not a great position to be in, but because they're an able-bodied adult, all you can do is encourage them, get them the resources they need, all that stuff.
Thanks for the clarification.
Yeah. Coding here, same as the others. I'm laughing because this gentleman, come here.
Liz, I was just curious, like how often like we're likely utilizing like these codes in over like the others that we've kind of been going over.
Depends on your setting. If you're in the ER, you're going to use these a lot. In my setting, I use them if, you know, because I'm not the one doing assessments, I code them and then I call in the report. It just depends, right? So if you're treating the person for PTSD, you know, you might add this again to explain the PTSD, although you don't have to. If they don't have, you know, the symptoms of PTSD, but they tell you as part of your assessment process that they were abused at one point, then you can add this, right? Again, it's really just how you want to add, you know, your full clinical picture. I find it useful just because I like having, you know, a nice, neat little ordered lists of what a person has been through. But it depends too on, you know, let's say the person doesn't want things like this reported to their insurance, stuff like that. Those are all things to take into account when you're working with the client. Again, if they're an adult. Psychological abuse. Again, clinical definitions, not legal definitions. Subjective based on what that client is feeling or going through or what you see happening. There are lots of different clinical styles when it comes to dealing with issues of abuse. Some people will say to their client, like, you are being abused, right? Others, not so much. They want to kind of help the client get to the point where they realize it themselves. Neither of those is right or wrong. It depends on you. It depends on the client. Some clients don't do well with that approach. Others do. Some find it really, really validating. Others get really defensive. Keep in mind that if your client has access to their chart and they deny, you know, you need to be careful. Same codes here, initial versus subsequent encounters. And similar codes here, services for victimization, personal history, or services for the perpetrator. I have a client right now who is seeing one of my colleagues for couples therapy, And she was like, this guy definitely needs individual therapy, send him over to me. And he is describing to me behavior that to me is very clear sexual abuse. But he doesn't realize that and doesn't get it. I'm not seeing him for sex offender treatment. I'm seeing him for his own traumas. And so would you or would you not in that scenario code it as an encounter for mental health services for the perpetrator? What do you guys think?
I would say no. I mean, you said before, if that's not what you're seeing the person for, and I mean, if you don't have anything you can report, I mean, depending on what they you may just like, there might not be enough information there. So like, might feel icky, but you really can't.
Yeah. And that is where things get uncomfortable, right? In this particular situation, the client comes in and I had a really bad day. My wife and I got into a really big fight because she says that she feels like I pressured her, but I don't think I did. In that scenario, I tried to use my clinical interview the best I could to kind of lead him to realizing here's why your wife is upset, or here's, that empathy piece. Let's figure out why she might have said that, right? And kind of help him overcome his own sort of rigidity around those issues. This person is also sort of borderline intellectual functioning. So he also wasn't getting it for that reason, because it wasn't this black and white sort of force, right? And yeah, because I'm not doing sex offender treatment, did not end up coding it. Things could get icky there. Savannah, looks like you have your hand raised.
Yeah, I am curious. I know you just said that you wouldn't really report that instance, but what comes to my mind is, so they say that, okay, this event happened and you try to lead them to that conclusion. But if it's somebody who is regularly doing that, would that change into a situation where you'd have to report because somebody's safety is at risk?
That is a great question. And we're actually going to talk about that when we get to our ethical legal issues next week. There's a difference between duty to warn and duty to protect. And yeah, we're going to talk about that next week. So I hate to leave you hanging, but that is a whole other conversation that we're going to get into when we get to the ethical and legal issues.
That's okay. I'll look forward to it.
Yeah. And if anybody really wants to dig into that further, look up and see, is Oregon a duty to report, or sorry, a duty to warn versus duty to protect state, and what is the difference? Yeah. Adult abuse by non-spouse, non-partner. So this could be everything from elder abuse, roommate abuse, persons being stalked by a stranger, all that kind of stuff. Also includes physical, sexual, or psychological, does not include self-defense. Notice how the DSM uses the wording physically protecting oneself as opposed to self-defense, because self-defense tends to be a legal term. So all the same sort of examples here, non-exhaustive list. Coding. Pretty much all the same codes. You're not expected to memorize these. Now let's go into less depressing things that clients will come to you for. So somebody's having trouble in school, somebody's having trouble at work. And this could be in addition to a learning disability, or it could be something else, right? Maybe it is they are in a new school, but they don't meet the criteria for adjustment disorder. Maybe they don't get along with their teachers. It could also be things like they are not literate, or things like they are bilingual, but they're not literate in English. And so that's causing issues at work. And so they're coming to you for help and support, all of those kinds of things. So again, not a disorder, just describing what the person is coming to help for. These are things that, you would code just because you're providing support, but they could also be used like if the person needs some kind of accommodations, right? So let's say you have a client who's low literacy, but they're really needing some extra help. That's about a break. Yes, we will take a break. Yeah, let's take 2 breaks today. Let's do 5 minutes right now so that everybody can recoup from all the super sad stuff. And then we'll do 5 minutes later before we get to the medical stuff. So it's 10:35, come back at 10:40. All right, I'm going to give everybody a few seconds to get back. Looks like pretty much everyone is around. So the next several codes are going to be things that, again, you will use if you're doing some sort of full workup on a patient. You've done their first assessments. There are jobs out there where your entire job is to do intake assessments, and that is where these kinds of codes are really, really useful. I personally really like these because it provides a nice, neat, concise little summary. If you don't have time to read the full assessment and you haven't gotten there yet, or again, if you're just trying to describe what this person is coming to you for. So once again, not disorders, just clinical issues, things that are normative human experiences, but that they might still need some extra help or support with. So academic or educational problem, we talked about that briefly. Occupational problems. So why do you think that the military deployment status would have its own category?
I think there's tremendous stress on members of the military and their families that affect all arenas of their life.
Absolutely. Absolutely. So yeah, clinically, it is extremely, extremely significant. And normative human experience. If you are in the military having issues related to your deployment, that's going to happen. We are not going to include things like adjustment disorder or depression, other things. We might add this. Or if they don't meet, if they don't meet full criteria, we would just use this code. The other reason for it is sort of the logistics reason. The VA, as you all are aware, has not always had the best reputation when it comes to medical or mental health care. And about 20 years ago, that started to really change. And so there's been a big, big, big collaboration between the Department of Veterans Affairs and the APA to incorporate more veteran-specific issues into the DSM and mental health treatment in general. So like SAMHSA, for instance, has some veteran-specific resources, all that kind of stuff. That being said, there are other people who have similar issues, right? So let's say the client is a trucker and is going to be gone for a week, weeks at a time or whatever, or some other kind of traveling job. You might consider that to be, another problem related to employment because they're having trouble coping with it. Other issues with employment could be things like they just hate their job and they're miserable and they come to you for guidance. It could be that they have a hostile work environment and they are just needing help coping with that. All of those things. So again, not using legal definitions. This is what this client is coming to you for. All that kind of stuff. Could even be maybe they're dealing with unemployment. We see this a lot with folks that, maybe they don't meet full diagnostic criteria for depression, but they're starting to really, it's really affecting their self-esteem, it's affecting their self-worth, or they're just, needing some help with, support with dealing with those kinds of issues.
I have a question about the military status. So say somebody moves a lot because they're in the military and then their child is having a hard time. Would that still fall under here, or would that be more adjustment disorder for somebody having a hard time adjusting to the constant moves?
Yeah. So if they meet full criteria for adjustment disorder, put the adjustment disorder. If they don't, then don't, right? But if it's, both, let's say it's adjustment disorder and it's due to this, then I would put both. The fun thing about adjustment disorder is that it's, what was the exact criteria? It starts within 3 months. And after the stressor goes away, the symptoms don't persist more than 9 months. What if the stressor never goes away, right? What if they're moving every 3 months or every 6 months? And if they still meet the full criteria, then absolutely put the adjustment disorder. If they don't meet the full criteria and it is just this ongoing stress of the moves or whatever it is, or, my parent is being deployed, then don't. Where are we at? All the way down here. I should really start paying attention to the number of the slide because that would make this a lot easier on myself.
To kind of piggyback on what Nancy just asked. So what you're saying is the military deployment doesn't, it could be your spouse's or your parents' military deployment that we're referring to. It doesn't just have to be the deployed person.
So the way that this is written, you would use this particular code for that.
For the individual, you mean, who is deployed?
Yeah.
What
But you could
about,
also add, yeah, you could change the wording and put, problem related to parents' military deployment status or problem related to spouses' military deployment status. And you will see ICD codes for all of those.
oh, really? Okay.
Mhm.
And where do you find those?
Oh, let's see. You can
It's
go.
okay. Maybe
Yeah.
you don't have to
No,
answer.
you can literally just Google like all of the possible ICD codes and they are there. You will find a list of thousands of ICD codes. It's actually kind of nice because some software, for instance, Simple Practice, the software we use at my practice, I can just type something in and it will pop up codes that I didn't even know existed because they're not in the DSM. But they're codes that are there for, again, describing what's actually happening for the person. And there are other codes for things like parent-child separation, right? Or relational issues, that sort of stuff. Housing and economic problems. Homelessness versus inadequate housing. Homelessness is living outside or in some sort of structure that's not fit for human habitation, like a cave or a tent. Your DSM gives you specific examples as opposed to inadequate housing. So this is where the person has housing, but it's inadequate, like there's not heat or plumbing, there isn't water, stuff like that. The definitions here get sticky. As a social worker, my job is to get people services, or it has been in the past. And so, to qualify for certain programs, for instance, in the state of Oregon, a person either has to have 12 months I think it's chronic homelessness. They either have to have 4 different instances of homelessness in the last 2 years, or they have to have 12 months consecutive, which I don't agree with because I don't think a person should have to wait until they've been out on the street for 12 months to get help. And so there are different definitions, right? Like, is a shed, is that considered homeless? It's a structure, but it's not fit for human habitation. Would you consider that inadequate or would you consider that homeless? Depending on how the client sees it versus depending on how you see it and what kind of services they will get. The other one that comes up a lot is couch surfing. The state of Oregon does not consider that homeless. Even though that person does not have a home, they don't have stable housing, they're staying with different people every other week. The state does not consider that to be homeless because they are indoors and they have water and light and electricity and stuff. Clinically, I would call that homeless because I am a clinician working with the client, helping them cope with this issue. If you're working in some sort of social service agency, you might have to kind of bend things a little bit depending on what feels right to you ethically. I have worked with agencies who, and this was not my idea, but I thought it was brilliant, where the person's been homeless, but in order to qualify for certain types of housing, they had to be chronically homeless. So to get that 4 episodes within 2 years, they would do things like buy them a motel room for one night because now they have 2 episodes of homelessness, so on and so forth. So once again, you're not looking at the actual social service definition, you are looking at the clinical definition. As the clinician, I'm still helping that person cope with their homelessness, whether it's a hotel, motel, couch surfing, whatever. Discord with neighbor, lodger, or landlord, pretty self-explanatory here. Person's got issues, right? They don't love their roommate and they're coming to therapy because they want help with coping with their roommate. Cool. It could also be things like, if you haven't seen it yet, there's a new Netflix special called Worst Roommate Ever. And it's interesting. It ranges from squatters to my roommate that murders people. All over the place. So if you are treating somebody in that situation and helping them deal with that issue, that's the code you would use. Problem related to living in a residential institution. So this is going to be things like your client is in a group home, your client's in the state hospital, whatever it is, and they are specifically having issues because of that. you know? And this could be a lot of different things. Like, I'm an adult, but I feel bad about myself because the state says that I can't take care of myself, or I'm having trouble coping with that. And again, they don't meet full criteria for adjustment disorder, or if they do, you're adding this in additional and you're saying this is why they have adjustment disorder. I thought I saw somebody's hand up and then it went away. Did somebody have their hand up?
That was me, but you answered my question right after I thought of it. So
No worries. Additional things that you can list here. I list these a lot because, again, in trauma therapy, these are things that contribute to whether or not people feel safe. Right? So like my low income clients, I'm going to put a low income code there because that, to me, that is an ongoing stressor. And it's something that that person probably talks about a lot. All of those kinds of things. Insufficient social insurance or welfare support. The DSM also provides a little paragraph about this. This is things where the person has applied, but they don't meet criteria. This is in there because our system is based off of some really, really, really old definitions. For instance, to get Social Security, let's say you have a disability, you get $700 a month, unless you have a work history. If you have a work history, you get a little bit more. And if at any point you have $2,000 or more in assets, your Social Security gets cut off. So let's say you're homeless, but you're trying to save up to get an apartment and you need deposit first month's last month's. Guess what? That's more than $2,000. You better not put that in a bank, because if you get caught with that in a bank, your income gets stopped. That's a whole thing. Or let's say you had a really, really good job and then you lost your job, but based on last year's taxes, you do not qualify for OHP, so you don't get to have healthcare even though currently you have no income. Or let's say you had a really good job and you have a little bit put away for retirement. You don't qualify for healthcare because you have a few $1,000s sitting in savings, and heaven forbid, you know, you want to keep that money and still get good healthcare. So that code is there for anybody who needs extra support, but the support is insufficient, or they're not qualifying for some kind of other reason. And it's, or maybe they're getting the support that they need, but it's not enough, right? $700 a month is not a lot to live on. It was, you know, 80 years ago when we defined the federal poverty level and came up with those, you know, equations to determine how much a person makes, but it is not enough to live on now. So if that's something that you're seeing, then code it. Or if that's something that your client is talking about or is contributing to their current issues, right? Let's say they meet full criteria for a depressive disorder, but then they start talking to you about their life and it turns out that they are living in extreme poverty. They're having all these other issues, you know, add all of those, because it helps paint that full clinical picture of what is this person dealing with? What is, you know, what is contributing to the depression, the anxiety, or whatever else the issue is. Phase of life problem. So this could be just, again, normative human experiences, normative human responses to regular stressors, right? So a person who's going through retirement, that can be really tough to cope with. A person is going through menopause, a person's children are leaving home, they've got empty nester syndrome, all of those sorts of things. You could add the phase of life problem code to describe what they're going through. Problem related to living alone. So things like loneliness, feeling like they can't keep up with chores, you know, and not everybody experiences that, right? Some people really like living alone. Not everybody does. So the people that are really struggling, maybe this person's gone through a divorce or they are living out on their own for the first time and they're struggling. That could be, you know, that could be what you put there. Acculturation difficulty. So again, normative human experience. You've been plucked out of your culture and placed in a new one. That's going to be tough. Social exclusion or rejection. This could be things like they're being bullied. They are struggling with feelings of unworthiness, you know, maybe they have depression, maybe they don't. This could be somebody who's really struggling with things like dating, all kinds of stuff there. I use this a lot, especially with kiddos that are dealing with bullying. because again, it's just describing what they're going through. And you can use this as a standalone issue, as, you know, again, just a normative response to human experience, or you could use it as an additional code if they meet full criteria for something else like an adjustment disorder or anxiety or social anxiety or whatever. Target of discrimination or persecution. Note that the DSM, the way that they describe it is actual or perceived, because regardless of whether or not you agree with what the person is telling you, if that's what they are experiencing and that's what they need help with, that is what you are going to help them with. Right? So, and personally, I feel like if you don't actually believe them, maybe it'd be better to send them to a different clinician, right? Or get some sort of cultural consultation, because there might be things that that person perceives as discrimination that you maybe just don't understand, and then you would want to get that extra consultation. And let's say this person has some kind of like, let's say that they are not a member of a marginalized group. Let's say they meet full criteria for paranoid personality disorder, and they believe that they're being discriminated against or persecuted for some reason, right? Like, let's say I've got somebody who is a member of the dominant culture, but they believe they're being discriminated against because of that. I'm probably going to code it this way. I might not agree, but if that's what they're experiencing and that's what they're wanting support with, that's what I'm going to code. And then unspecified problem related to social environment. So this could be issues with friends, all that sort of stuff. Anything that isn't better covered by a different code. Problems related to crime or interaction with the legal system. So if they've been the victim of a crime, if they have been convicted, if they are incarcerated, if they are struggling with being released from privilege or from prison, or if they're having other legal issues. If your client is in the middle of suing someone or being sued and it's really stressing them out, that would be a problem related to other legal circumstances. I have a client right now who there's a lawsuit for a wrongful death. So the full diagnosis list, it's a family, and one of them has PTSD because they witnessed the death and they meet full criteria for PTSD. There is a complicated grief bereavement issue, and there's a problem related to other legal circumstances because of the lawsuit. So all of those are accurate. If you're doing sex counseling, this would be all the examples they give there. If you're doing some other kind of health counseling or consultation, so like the state has a very specific nicotine cessation program that folks can enroll in. That's, you know, you would use that code here. It could be other health issues. And again, in addition to or separate from adjustment disorder, illness, anxiety, etc. Let's say like with sex counseling, maybe they meet, you know, the full criteria for one of the sexual disorders that we talked about earlier in the term. And then that day, that is what you are focusing on. So you might add the counseling code for that day. These are used a lot more in medical settings too, because that's usually where V codes show up because it's a one-time encounter. But, you know, if that's what you're treating the person for, helping the person out for, helping the person out with, feel free to add it. Other problems, all kinds of things here. So a religious or spiritual problem. This comes up a lot. You know, the person's experienced a death and now they're questioning their faith. Or if you are doing some sort of pastoral counseling, this is probably what you're going to be doing. Problems related to unwanted pregnancy, problems related to multiparity. I'm having triplets and I didn't want them. How do I cope? All right, let's talk about that. Or I'm pregnant and I don't want to be. I'm having trouble coping. Let's talk about that. Discord with other providers. I've never used this code, but I think it's great that it's there. You know, let's pay attention to issues like splitting, right? Especially if you're in one of those settings. But let's also, you know, let's say you work in an agency and that is all they ever talk about is how much they hate their PO. You know, let's add that code. Victim of terrorism or torture. Exposure to disaster, war, or other hostilities. So if you work with refugees, there are several refugee programs in the Portland area that any of you could get a job at. You'll be seeing those sorts of codes a lot. And then other problem, where you would add a specifier or unspecified problem. Maybe they hate their professor and they need to talk about it. That would be other problem. Maybe they're just generally hateful and they need to talk about it. That would be an unspecified problem. Other circumstances of personal history. I use these a ton. Again, as a trauma therapist, it makes sense, but depending on your setting, you might not. Anytime somebody tells me they've self-harmed, I'm going to add that to their chart because it keeps me aware, keeping an eye out for it. Even if it was 20 years ago, if the person's talking to me about it, it means that it must matter to them. And so I'm going to add it. When we say personal history, typically this refers to things that the person is telling you. If they don't tell you, but it's in their chart, you would probably want to make a note of it. Whether or not you code it is up to you. I would probably ask them about it and then get that personal history. If they've been deployed in the past, if they have a history of trauma, all that sort of stuff. Problem related to lifestyle. This one's really, really, really subjective. So the DSM gives some examples like issues with nutrition or exercise, but it can also be things that that person is subjectively talking to you about. You know, maybe they feel like they play video games too much or something. I've never actually seen that coded, but you might use it for things like, let's say that person, and here's a fun one. Let's say you're working with somebody who's a sex worker, not a sex trafficking victim, but a sex worker. And they are just having trouble coping with the stress of the job. Would you subjectively call that lifestyle, or would you call that an occupational problem? What do you think?
I feel like I would think of it as an occupational problem. But since you're asking us while we're looking at the lifestyle problem, I'm wondering if that might be the clue that that's what the correct answer is.
I mean, I personally would probably also put it as an occupational problem, but I also have really strong views on that particular issue. And it comes up a lot in the Portland area because we do have a rich history with the sex industry. So you might work with a lot of folks that are dancers, former dancers, full service sex workers, that kind of thing. If somebody put problem related to lifestyle, I might kind of side eye them a little bit, but it would also depend. Let's say they are a dancer and their job requires them to be up until 3 a.m. and they're struggling with that piece, right? They don't get to see their kid enough or something like that. Maybe that would be lifestyle, but you could have that lifestyle with another type of work too. So it would really depend on what I'm not going to put it lifestyle. I'm not going to put problem related to lifestyle because I have some sort of moral issue with the type of work. If it's purely work related, I'm going to put occupational. If it's lifestyle, maybe it's related to work or not, then I'm going to put lifestyle, right? In that case, we would also look at things like sleep disorders, whether it's a circadian rhythm disorder, those sorts of things. Adult antisocial behavior. So this is somebody who does not have a personality disorder, but they have engaged in some sort of behavior. Child or adolescent antisocial behavior. So again, they don't meet full criteria for one of the other diagnoses. Whether or not, and this is another one of those subjective things, if they are engaging in what we might call antisocial behavior for survival, that is sort of up to you and your ethics to decide whether or not to code this. Yeah. I'm currently rewatching The Sopranos and really enjoying the therapy sessions. And I was thinking about that as I was typing this up, like, would I code that as antisocial? I don't know. Haven't watched it in like 15 years, so remains to be seen. unavailability or inaccessibility of healthcare facilities, unavailability or inaccessibility of other helping agencies. This isn't just going to be things like inadequate social welfare. This could also be things like your client needs surgery and they can't get it. Your client wants an abortion and they don't have access. Again, we are not using any sort of moral judgments here. We are just saying it is inaccessible or unavailable, and that is what they are talking about. That's what they're struggling with. This could also be things like maybe they live in a really, really rural area and they have to drive 6 hours to the nearest hospital, but you're seeing them via telehealth or whatever it is. All of those sorts of things. Non-adherence to medical treatments. I've only ever seen this coded once, and it was because we had a client, I think I mentioned this before, it might have been in the other section. We had a patient at the state hospital that had cancer, did not believe that he had cancer. It went up the whole, I think I mentioned it went up the whole chain of command to an ethics committee before they could decide whether or not to involuntarily medicate him. But basically was declining treatment because he did not believe that he truly had cancer. Overweight or obesity. Why is this listed under non-adherence to medical treatment? What do you think? It is listed that way in the DSM. I saw Megan shake her head.
Yeah, I guess I just don't know. I can imagine that we may have clients that come to us that are struggling with kind of symptoms of being overweight and obesity.
Yeah, this is one of those icky feeling codes because non-adherence is a behavior. Being overweight or obesity is a state of being, not a behavior. So if you're assuming it's because they're not adhering to medical treatment, maybe you would put it. I don't make that assumption because as a public health person, we also know that both, being overweight or obese has far more to do with large scale population health issues like food access, nutrition access, stress, trauma, all of those things. The only time I would code this personally, and again, this is up to you and sort of your ethics, I would code this if, say, my client was depressed because of it, and then I would add it. Or if my client is struggling with some kind of other, maybe they have social anxiety and a lot of that is due to things like embarrassment because of their weight, then I would code it. And then I'm going to help them cope with that. And I'm going to work on, acceptance and other issues. Because we know, most of the research shows that it's not, isn't helpful, right? Doesn't really help the person if they are experiencing a lot of shame or guilt about things like that. So it'll be interesting to see what that looks like in the TR when it arrives, if that's still there or not.
I'm curious, like if somebody had a gastric sleeve or something like that, like something related to a medical procedure.
Yeah. Then that would make sense, right? Let's say they've gotten gastric bypass surgery and they are continuing to engage in behaviors that's unsafe, then I might call that non-adherence to medical treatment. But I would probably still code that with this first one here, which is not adherence to medical treatment, not necessarily overweight or obesity, because again, those are descriptions, not behaviors, right? We can extrapolate all sorts of behaviors we think are happening, but I don't know. To me, those are not behaviors, but that is my personal opinion. So you can take that as you will. Malingering. Malingering is an interesting one. We're going to talk about this for a couple minutes, but not super long because we have to move on to the medication-induced disorders. Although, depending on how long, maybe we'll do those next week because this is one that I think warrants good discussion. So what do you think makes malingering different from factitious disorder?
It's the intentionality piece, right?
Yep.
Malingering is you're doing it on purpose.
100%. Well, 99%. They're both on purpose, right? The intentionality piece, though, One is for a known purpose, the other is for an unknown purpose. So remember, with factitious disorder, we might think we know the purpose, but malingering is when we know for sure that there is some sort of secondary gain. So it is an intentional production of false or grossly exaggerated physical or psychological symptoms motivated by external incentives. Remember, we can diagnose factitious disorder in the absence of external incentives. So they also make a good point here that it can be an adaptive behavior, right? Feigning illness, well, captive of the enemy during wartime, but it doesn't just have to be that, dramatic. It could be feigning illness because they're in an abusive situation at home. There's a book called Room, and it was based off of a real case, and it's slipping my mind right now, the name of the case, but it was a woman who was being held hostage, and she gave birth while in that situation, and she had basically had the little boy pretend to be dead so that the man that was holding her captive would take him somewhere, and then the little boy escaped and got help, right? So things like that. That is feigning an illness while captive, but for other reasons too. Sometimes this could be things as simple as your kid has an exam coming up and they don't want to take it, so they pretend that they're sick at school, right? All sorts of things. I would be really, really careful with diagnosing malingering unless you have objective evidence, because once a person has this label, it's really hard to get rid of. And sadly, as we've seen with some other diagnoses, once they have that diagnosis, other diagnoses tend to not be taken as seriously. So let's say there was an instance where they were engaging in malingering type behavior, but then later they really do develop an illness. You want to be careful, and you want to be careful when you see that as well, that you're not extrapolating from then to, the current problem. Let's see here. We want to also differentiate between malingering from something like conversion disorder, or somatic symptom related disorders. Because with those, the person is truly experiencing the symptoms, as opposed to malingering, they are not. They are intentionally producing symptoms. So some things to look for. There's actually psychological testing for malingering that some of you will get trained in how to do. That's a great way to rule it out. Or if you have questions, that's a great way to rule it out. Like when I worked at the state hospital with our aid and assist population and with our guilty acceptance sanity population, they always tested for malingering for obvious reasons, right? Because it could make the difference between whether a person goes to prison versus gets the treatment that they need at the state hospital, and so on and so forth. So there are actual objective measures that can be used to test for malingering. There's effort testing, all sorts of stuff. Let's see. If they have antisocial personality disorder, take a look. That is one that the DSM purposely adds in there. But again, it would be for some, it still has to be some, these are all sort of red flags, but not definitions of the diagnosis itself. So these down here, red flags, but the actual definition would be up here. So we talked about some of the differential diagnosis, factitious disorder. Maybe there's evidence that they're feigning or inducing the symptoms, but just like Greg said, we don't know what the intention is, if there's clear external motivation or not. And then conversion disorder, somatic symptom related disorders do not include feigning or inducing symptoms. Thrown in here sort of randomly at the end of the DSM, relevant to neurocognitive disorders if the person engages in unsafe wandering. And this doesn't just have to be neurocognitive disorders. This can also be things like a kiddo with adjustment disorder, so they're running away a lot. It can be things like a patient who is schizophrenic and they think they're somewhere where they're not actually, and so they wander away, right? This could be the kid that's autistic and they just go wandering or whatever, it's associated with another mental disorder.
Could it be substance abuse?
Oh yeah. Like got super, super drunk, took themselves on an adventure. Sure. And, if they are coming in for an acute issue, you're going to diagnose it, but it's more often seen if it's something that happens regularly. So if they're drunk all the time and take themselves for adventure, sure. If they got drunk once and took themselves for an adventure and ended up at the ER, you know, we don't know how, you know, we were the first one to assess for the substance use disorder. You could probably diagnose, you know, alcohol intoxication and then the wandering associated with that. But the most common times you're going to see this is with neurocognitive disorder and then with disorders of childhood. And last but not least, borderline intellectual functioning. So this is when it's an issue for the person, but they don't actually meet full criteria for an intellectual disability. So these are folks that are of below average or in the low average intelligence range, typically in the 70 to 80 IQ range. This can also be folks, let's say they do IQ testing and they get like a 90 in verbal, but they get, you know, a 70 in like reasoning abilities or spatial abilities. This is going to be based on both the testing, but also ongoing assessment if they're struggling as a result of it. This is something we add a lot just because if it is accurate, because it also helps you understand what sort of therapies are going to be most useful for the person. Like if I have somebody that is really, really, really struggling with trauma and they're borderline intellectual functioning or even IDDD, I'm probably not going to do some of the deeper, more sort of abstract type trauma treatments. I might do a more somatic based treatment, which I shouldn't say more deeper because somatic based treatment is very, very deep. It's just less verbal. I might do more concrete types of treatment with this person. I might need to adapt, let's say they, in addition to low, you know, borderline intellectual functioning, they also have borderline personality disorder. I'm not going to be able to do regular DBT because of the level of abstraction that requires. I'm going to do an adaptive DBT curriculum, things like that. It's just one of those things that's also just good to know about your client. So we are going to shift gears and talk about medications. However, it's only 11:20. It is going to take longer than 40 minutes to talk about this section. So we can either finish early today and do this the first half of next week, or we can start it, get through what we get through, and then finish it next week. Who wants to do option A? Say so in the chat, or option B. And you can message me privately if you don't want to show everyone your votes. All right, well, I've only gotten 2 Bs and 1 either, 2 either's, majority A's. So we're gonna go with Democratic and do A. And I have had a couple people message me and ask about extra credits. So if you are in need of extra credits, before we do next week ethical, it's funny because the ethical and legal issues is a fairly short lecture, and so that works fine. If you are interested in extra credits and you have, let's say, a B or below, if you have an A and you submit me extra credit, I'm going to be mad at you because that's extra work for me that you don't need. But if you have, let's say, a B or below and you want extra credit, find out for me if Oregon is a duty to protect versus duty to warn, and write me a paragraph or 2 about what that means for you as a clinician. And we'll call it, I don't know, 5 points. Make up for a thing of case studies plus some extra. Sound good? All right, cool. Because then you'll all have good things to discuss next week as well. If you want to review the stuff for medical, you can. You don't have to. There are a couple videos, but that lecture will take about an hour. And so we'll do that next week. And I hope you all have a lovely week and enjoy the snow/freezing rain, whatever that is. All right, and as always, email me with questions, concerns, anything I said that was off color or offensive, or things you would like more research on, let me know, and we will address those next week. All right, bye guys, be good.
Thank you.
Hey, Liz.
Thank you.
Oh, this is Trent. Sorry. I was a few minutes late. I just want to make sure that you got me.
Yeah, you're good. So
Okay.
the way I do attendance for these is I just go on the Zoom analytics and I see who showed up,
There you go.
right?
Perfect. I'll be
Like,
there.
you could turn your camera off and lie to me, whatever. If Zoom says you're here, objectively, you were here.
Awesome. Thank
All
you.
right. Yep. See you next week.
Liz, do you have a second to, don't you have clients right away?
Yeah, but since we're home today, I don't have to drive an hour, so you're good.
Kira, I don't want to take over if you have a quick thing. I wanted to ask Liz a couple of things about the online test that I think would be easier to discuss than email about. So I was going to stick around for that.
Depending on your questions, we might actually be talking about them next week. So since
I
it's
just think my experience might be interesting for you to hear about.
Yeah. Is it
Kira,
something
do
you
you
want
want
to
me to
talk
go
privately?
first?
Yeah, mine was just a very quick question.
Okay.
I stepped away to grab a snack and then I came back and people were saying A or B.
Oh, we were debating because the second half of today is going to be on medication-induced diagnoses, but that's a pretty long section. And so I was asking folks if they wanted to do that now and then, break it in the middle and finish it next week, or if they just wanted to do it next week.
And I'm guessing people said next week.
Yes, and the syllabus has it listed for today, and then next week's being a little bit of a shorter lecture. So instead, next week's will just be the full time instead of, done halfway through.
Great, sounds good. I just was like, oh no, of course I stepped away.
No, you're good. Even if you had said B, you would have been grossly outnumbered. So
I was like, what do you mean? Okay, thank you.
Mm-hmm.
Kira, good to see you.
Good to see you too, Megan.
Bye. Okay, so Liz, I'm glad
let
we
me
have
turn off the recording because I don't
okay.
need everybody knowing your business.
Thank you.
Yeah, of course. How do I do?